The second session will be two case presentation from the Department of Internal Medicine, Amrita Hospital, to be presented by Shashank, Sudeep, and Eunice, Susan, resident DNB residents. I request Dr.Renoy Henry to come forward and conduct the proceedings. Dr. Renoy Henry is the Professor of Internal Medicine, Amrita Institute of Medical Science. Over to you, Doctor.
Thank you, sir. Good evening and a warm welcome to the case presentations from Amrita. Before I start, I just would like to make a point. I think case reports and case presentations are actually dying down. If you look at most of the conferences, CMEs, and even journals for that matter, preferences are given for original research articles as well as case series and things like that now. So I think it is very important as a physician in training, especially the students here, to actually understand the importance of a case presentation, the common presentations of common diseases, its variations, how to actually investigate, because there are a lot of a flood of investigations that are available, which actually PGs gets confused quite a bit. When to refer, I think that is already being mentioned earlier. And all those things, including treatment options as well as prognosis, we get from listening to these case presentations. So without any further delay, we will start with the first case. Prior to that, I would like to thank the organizing committee of API Kochi to have given us this opportunity on behalf of the head of the department and the entire faculty and Department of Internal Medicine, Amrita, for giving us this wonderful platform. We'll start with the first case presentation by Dr. Shashank Sudeep. He's chosen to title the first case presentation as From Masters to Lenses. So let's learn from him why he chose to do that. Thank you. Over to Dr. Shashank.
Good evening all. I'd like to thank API for giving us this opportunity to speak at this event. So my case would be titled From the Masters to the Lenses, and it is a case that we encountered in one of our IP patients. So the case is a 40-year-old male from Maldives, businessman by occupation, also a known case of epilepsy disorder on valproate 500 mg twice daily, and benign prostatic hyperplasia on tamsulosin 0.4 mg at night. So he presented with chief complaints of lower back pain for a month, abdominal pain for 20 days, and a fever history for 20 days. So moving on to the lower back pain, it was insidious in onset, dull, aching, progressively increasing, and worse at night. It's also increased with walking, but it is also present at rest, and there is no radiation to legs as well. Fever history of 20 days was high grade, intermittent, associated with chills and rigors, more at night, associated with a generalized weakness, loss of appetite, and associated weight loss of 8 kgs over 2 to 3 months was noted. It was also associated with increase of pain abdominal pain during the fever spikes. There was no history of any cough, sore throat, vomiting, headache, joint pain, loose stools, or other localizing symptoms. The abdominal pain was also insidious in onset, diffuse, poorly localized, dull, aching, not radiating, no referred pain noted, not associated with food intake, no changes with posture, no complaints of vomiting, loose stools, or any abdominal distension. Moving on to our examination, patient was conscious, oriented to time, place, and person. Vital signs were significant for a temperature of 101 degree Fahrenheit. General examination was significant for pallor, but there was no icterus cyanosis, clubbing, edema, or any clinical lymphadenopathy. Systemic examination, the gastrointestinal system was soft and diffuse tenderness was present, no rigidity or guarding. The liver border was palpable 4 to 5 centimeters below the right intercostal margin, which was firm, and the liver span came up to about 17 centimeters. Bowel sounds were heard. Cardiovascular system and the respiratory system were grossly normal. As was the CNS was also grossly normal, no focal neurological deficits were noted. So at this stage, in our diagnostic journey, we consider the differential diagnosis of a chronic infection because there has been a prolonged febrile illness, a fever history for almost 20 days. So when we consider fever, it is the marker of inflammation. So we must always consider three different pathophysiological processes going on, either an infection, a malignancy, or an autoimmune. So based on these three buckets of illnesses, we prioritized our differential diagnosis. So chronic infections, being in India, extrapulmonary tuberculosis, always must be high because of the base rate, or any fungal infection or any atypical organisms like brucella we considered. Malignancy in view of the fever and the systemic symptoms like weight loss and anorexia. So a hematological malignancy like a lymphoma, or if there are any secondary metastasis from an unknown primary solid organ tumor, also was considered. Granulomatous diseases also can present with a prolonged febrile illness. So, and also it forms an important differential for the other two. So for completion's sake, we also considered various forms of granulomatous diseases, primarily sarcoidosis. And in view of the epigastric abdominal pain, which was chronic in onset, chronic pancreatitis was also considered by us. So moving on to the initial blood investigations, significant for a mild leukocytosis, differential remaining normal, hemoglobin of 9.9, an MCV of 84, platelet counts of 358. Liver function was showing a mild AG reversal as well, with that globulin on the higher side of normal. Liver enzymes were grossly normal, LDH was normal, ALP was normal. Inflammatory markers by way of ESR and CRP were elevated significantly. Apart from that, there was no kidney dysfunction. Electrolytes were normal. An emergency screen that we had sent for HIV, hepatitis B and HCV were all non-reactive. Amylase and lipase levels both were within normal limits. Moving on further, the peripheral smear was showing a normocytic normochromic anemia. The iron studies came back to show relative iron deficiency, but primarily based on the peripheral smear and the morphological findings as well. This would likely be more of an anemia of chronic inflammation. But in view of the iron deficiency, we had sent a stool local blood, which came back negative as well. So at this stage, he was quite ill. He was having constant fever spikes. His abdominal pain was also worsening. In view of his clinical presentation, he was empirically started by us on broad spectrum antibiotics, because initially we felt that it could be a possible sort of an sepsis with a possible intra-abdominal localization. So we started the patient on broad spectrum antibiotics. After sending blood and urine cultures, supportive measures like analgesics were also started. But throughout this course in his hospital, he continued to worsen, continued to throw fever spikes, and his abdominal pain was also increasing in intensity. So to further evaluate for the abdominal pain, we went ahead with a contrast enhanced CT of the abdomen and pelvis. Chest X-ray was normal. So the CCT abdomen pelvis was showing a soft tissue mass encasing the aorta, a retroperitoneal soft tissue mass which was encasing the aorta, as well as the IVC and bilateral common iliac arteries. So now, in view of our new imaging findings, we had to change our differential a little bit. So at the top came lymphoma. Extrapulmonary TB we still had in the running. Then in view of this retroperitoneal masses, so the prominent new diagnosis of IgG4 related disease, especially the type 2 phenotype, also came to us, because it has been noted in literature that a variant of IgG4 related disease, primarily the retroperitoneal and aortitis variant, have presents in a similar way to our patient. Sarcoidosis also was still, we still considered. To differentiate between all these diseases, we felt that further histopathological analysis would be necessary. So we went along those lines. Initially, a USG guided FNAC was done from the para-aortic mass and was sent for cytology and showed a paucicellular background and occasional scattered lymphocytes and neutrophils. The AFP smear was negative at this point, but the diagnosis could not be made due to insufficient sample. We at this stage, because the masses were situated so close to vital organs like the aorta, so taking a biopsy from that, an excision biopsy from those masses would be risky. So in order to assess for any other potential site for biopsy, we went ahead and did a PET CT. But the PET CT was still showing a metabolically active, ill-defined homogeneously enhancing soft tissue mass encasing the aorta, which showed an SU intake of actually 7. Also in this study, we found out metabolically active left lower paratracheal, subcarinal and para-aortic as well as common iliac lymph nodes. So a CT guided biopsy was done on consultation with our interventional radiology department and was sent for a histopathological biopsy. It was a CT guided biopsy from the para-aortic mass as well, which showed patchy aggregates of mature and reactive lymphoid and plasma cells with epithelioid cells with scattered eosinophils. So the impression was a mixed inflammatory infiltrate. The immunohistochemistry was positive for CD3 and CD20. At this point again, these samples were negative for AFP smear and gene expert, and there was no granulomas noted. So at this stage in our diagnostic journey, extrapulmonary tuberculosis could safely be ruled out, as even in the biopsy sample, the Mycobacterium tuberculosis panel was negative and the MAN2 test also done was negative. Sarcoidosis also can be ruled out at this stage, and we have normal calcium levels, and again no granulomas noted on histopathology. Lymphoma at this stage, we needed further IHC because pathologists felt a larger representative sample would be necessary. IgG4 disease at this point we were suspicious of, so we went ahead and sent a serum IgG4 level, which came back to be 88. A positive test would be greater than 135, but it must be noted that the sensitivity of the serum IgG4 level test is 80% and the specificity is 60%. So that means like it has a good negative predictive value but a poor positive predictive value. So as we had discussed with pathology, based on their opinion, they felt that a larger representative sample was required. There was only one more way to go about this, which would be an excision biopsy by way of surgical laparotomy, which is what we went ahead with. So this was the biopsy findings from the excised mass, from the excised retroperitoneal mass, which was showing multiple small lymph nodes with reactive follicles. Between the follicles, extensive fibrosis with a focal storiform pattern was noted. Patchy infiltrate composed of lymphocytes, plasma cells, and histiocytes were present. No atypical cells or granulomas were seen. So these are the slides. The one on the left is showing a reactive lymphoid follicle with lymph node hyperplasia. And the one on the right is showing the classical storiform fibrosis. The immunohistochemistry also, numerous CD138 positive plasma cells were seen. The IgG4 to IgG ratio was 40%. The IgG4 count in our tissue sample was 105. CD3, CD20 reactive follicles were seen, and no CD30 atypical cells were noted. This was the immunohistochemistry pictures. So at this stage, our diagnosis becomes quite clear. We had diagnosed this case as an IgG4 related disease. So based on the criteria given out by Umihara et al., so basically the diagnostic criteria for IgG4 related disease consists of 3 facets: your clinical and radiological features, a serological diagnosis, as well as characteristic pathological diagnosis. So in our case, we did have clinical and radiological features. as in we had a retroperitoneal mass on CT, which is characteristic of IgG4 related disease. Serological diagnosis we could not make in our patient as our serum IgG4 level didn't meet this cutoff. Pathologically, we did have dense plasma lymphocytic infiltrate. We did have storiform fibrosis. Our IgG4 to IgG plasma cell ratio was 40%, and our IgG4 positive plasma cells were also greater than 10 par high power field. Also, we did have typical tissue fibrosis, the storiform fibrosis, which was visualized on histopathology. So, if we move on to the criteria, we have 1 and we have 3. So, which makes it a probable IgG4 related disease. He was started on IV steroids, following which he showed a dramatic improvement clinically. His anorexia resolved, his abdominal pain resolved, his inflammatory markers also showed a marked decrease following steroid therapy. So he was discharged on steroid therapy on a dose of 1 mg per kilogram. So on OPD, he continues to be followed up at our department, and he was we continued to taper him with steroids. We also did a repeat imaging after 3 months, and you can see the results. To your left, you can see that soft tissue mass encasing the aorta, and to your right, you can almost see complete resolution of that mass, and there was no recurrence. Repeat inflammatory markers during OP follow-up were also ESR of 7, CRP of 1.26 significantly reduced. And currently he is getting azathioprine 50 mg 101 because due to his steroids he did develop a little bit of steroid-induced psychosis as well. So we had to taper these steroids quickly and introduce steroid-sparing agents as well. So moving on to some clinical pearls and some take-home points that we can learn from this case. So basically the definition of IgG4, the definition is basically it's an immune-mediated fibro-inflammatory condition. So there are basically 4 phenotypes or spectrums of clinical presentation. As you can see, our case came under the second group of retroperitoneal fibrosis with aortitis. So the other groups would be pancreatico-hepatobiliary disease or an autoimmune pancreatitis, which is likely the most common presentation of IgG4 related disease. Head and neck limited disease like orbital pseudotumors, thyroiditis, and the classic Mikulicz syndrome, which is just salivary gland and salivary and lacrimal gland involvement with systemic involvement. So the other systems that can be involved are lungs with a non-specific interstitial pneumonia pattern, ILD pattern, or your kidneys can also be included, either an acute tubulointerstitial nephritis or a glomerulonephritis. And as usual, pancreas can be involved, autoimmune pancreatitis also resulting in a diabetes mellitus, which is incidentally called a type 3C diabetes mellitus. So these are, and this is the basic immunological basis of the disease. So when we hear the disease IgG4 related disease, we think that maybe this IgG4 might be a causative or an implicated pathophysiological driving force, but actually it is not the IgG4 that causes much of the pathology in this disease, but rather your activated CD4 Th cytotoxic cell, the one which you can see as CD4-CTL on this figure. So basically there is a naive B cell. When it gets stimulated by your follicular T helper cells as well as your CD4 cytotoxic helper cells, which helps this B cell in survival, proliferation, and it also results in multiple hypermutations. So you can have like 2 possible forms of plasma cells, a short-lived plasma cell and a long-lived plasma cells. So here you have what is called as class switching between IgG1 and IgG4. Actually, all IgG1, IgG2, IgG3 also values may be elevated in certain particular phenotypes of IgG4 related disease. So basically our mode of management would also involve in modulating these different cytokines. For example, as we see this, the pathology is primarily driven by B cells. So if the patient is having an unusually high IgG4 level, patient is having severe multi-organ dysfunction, rituximab beta cell depletion with rituximab may also be tried, which is a CD20 anticlonal, anti-monoclonal. And other things, anti-fibrotic agents, IL-1 beta blockers like anakinra, TGF beta inhibitors, all these other drugs may also be used for in IgG4 related disease. These are other diseases that IgG4 values may be elevated in, as IgG4 is not specific for IgG4 related disease, but it is most commonly seen in IgG4 related diseases. Just moving on to the treatment, a 0.6 to 1 mg per kg dose of steroids is useful, and response may be seen in as soon as 2 weeks. Then tapering of steroids along with starting of steroid sparing agents can be considered. In severe cases, rituximab and other biologics may be considered. So these are novel mechanistic strategies for treatment of treatment of IgG4 related disease. Like rituximab, which is CD20, there is an anti-CD19 molecule in ebulizumab, which is coming up, and all these other monoclonal antibodies which work on the different phases of this disease. Thank you.
Thank you very much, Dr. Shashank. Now, I think it is important to understand that though this patient had a good kind of a remission here, after 3 months, this is a disease which probably can relapse at multiple levels later in the life, and also can sometimes present with secondary malignancies later. So it is very important that you actually follow up these patients actually on long-term basis regularly. So any questions? So if no questions, I think we'll move to the next presentation. Next presentation from the next presenter, that is Dr.Eunice Susan Thompson. She's going to present on a catastrophic illness, and let's learn from her why she chose to call that as a catastrophic illness. Over to you, Dr. Eunice.
Good evening. Today I'm here to present an interesting case which I've titled as Catastrophe. So let me introduce you to my patient. Patient is Mrs. S, a 45-year-old teacher from the hometown of Palakkad, Kerala. She was a known case of hypothyroidism on tap thyroxine 50 micrograms daily. So patient had initially come to us with the complaints. Patient had come to the hematology OPD with the complaints of generalized tiredness and fatigue. So the patient had come to the hematology OPD with the initial complaints of a generalized fatigue for 8 months duration, a neck swelling of 8 months duration, which was initially painful and painless since the last 4 to 5 months. She then had complaints of dyspepsia and hoarseness of voice since 8 months, with loss of 4 kgs in the last 4 months and loss of appetite. So initial vitals were a pulse rate of 82 per minute, BP of 150 by 80, a respiratory rate of 18, and patient was afebrile. On general physical examination, there was a lymph node of size 3 into 3 centimeter at the left side of neck, level 5, which was spherical, smooth, smooth-surfaced, mobile with no skin changes and no draining sinuses. To note, there was no other cervical, axillary or inguinal lymph nodes palpable at this time. Other general physical examination were within normal limits. Systemic examination was also within normal limits. There was no hepatosplenomegaly noted. So initial labs at this point of time were showing a hemoglobin of 10.3 with an MCV of 82, a total count of 21,000, CRP of 7.2 with an ESR of 62, and a significant albumin globulin reversal was also noted with an albumin of 2.7 and a globulin of 5.7. Peripheral smear was showing a normocytic normochromic anemia. At this point of time, our differential diagnosis included a lymphoma, tuberculosis, a metastatic lymph node, or a sarcoidosis. So serum protein electrophoresis was sent in view of the patient's age, elevated ESR and anemia, and it was showing a polyclonal gammopathy of undetermined significance. Kappa lambda ratio was 1.7, slightly elevated, with an IgG of 5,500. So bone marrow aspirate and biopsy was done as an OPD visit itself. Aspirate was showing a plasma cell of 5%. Bone marrow biopsy was normal. Coming back to our timeline, patient was then admitted under medicine with the same complaints for further evaluation. At this time, we had taken a revised history of the patient, and revised history showed two important history. One was that the patient had complaints of painful joints about 8 months back, for which she had taken traditional medicines, and patient was completely resolved. The symptoms are predominantly over the small joints of hand and occasionally over the knee also. Another history was that she had exposure to cats. Patient had actually fostered a family of stray cats which had died a few days later, and she had similar complaints in her mother also. So with this new history, our differential diagnosis included a tuberculosis, lymphoma, systemic lupus erythematosus, metastatic lymph node, sarcoidosis, and toxoplasmosis. So MANTO was done, it was negative. HIV screen, HBsAg screen, and HCV screen was negative. ANA, IFA, and ANA blot was sent. Serum ACE levels were normal. Toxoplasma, IgG, and IgM were also sent. We had at this time given an option to the patients for a whole body PET CT to look for any other lymph node involvement. PET CT was showing a metabolically active supra and infradiaphragmatic lymph nodes with diffuse FDG uptake in the spleen, and there was diffuse FDG uptake in the axial and appendicular skeleton also. At this point, our differential diagnosis again was a disseminated tuberculosis, lymphoma, toxoplasmosis, or a systemic lupus erythematosus. So at this time, the patient was advised for a lymph node biopsy. However, since the patient and patient party was not willing for the same, they were discharged at request. So 2 weeks later, the patient had come back to us and they had consulted in the general surgery OPD, and the level 5 cervical lymph node biopsy was taken. The excision biopsy was showing a paracortical hyperplasia. AFP smear and gene export from the lymph node biopsy was negative. A few words about paracortical hyperplasia here. Paracortical hyperplasia is usually seen in dermatopathic lymphadenopathy associated with psoriasis or eczema, which was not present in a patient, toxoplasmosis, EBV, or granulomatous lymphadenitis. So here I've shown a representative diagram of the paracortical hyperplasia. So this time we had also got a few new reports from the patient. One was that the toxoplasma, IgG, and IgM were both strongly positive. Anti-nuclear antibody screen was 4+, which was again strongly positive. The ANA blot report had come, which was showing positivity of SSA, SSB, and Rho52. The SSA antibody is commonly seen in Sjogren's syndrome, SLE, or polymyositis. The SSB antibody, when it's present with an SSA, is specific for Sjogren's and also can be present in SLE also. And Rho52 is commonly present in SLE and then in Sjogren's also. So this time the patient had come back to us after a span of 2 weeks, and at this time the patient was readmitted under us with the complaints of fever of 1 week, which was low grade, no chills or rigor, and multiple episodes of vomiting for the last 4 days. So retrospectively, giving the recent reports that we had asked her if she had a history of dry mouth, and she said she did have such history in the last 1 year. So this time we had sent for the labs again, which was showing an anemia of an hemoglobin 9.9 with a total count of 12.3, hyponatremia, hypokalemia, hypocomplementemia with an albumin globulin reversal again, and direct Coombs test was also found to be weakly positive. Blood cultures, urine cultures and chest X-ray was normal. So in view of the patient's persistent hypokalemia, even with IV and oral corrections, we wanted to evaluate further for it. So we had sent for a blood gas analysis. It was showing a metabolic acidosis with an anion gap of 11, urinary potassium loss of 28 and TTKG of 7. So in view of the patient's normotensive nature, recurrent hypokalemia and renal loss of potassium, a possible distal renal tubular acidosis was considered. So distal renal tubular acidosis is commonly seen in Sjogren's, associated with Sjogren's, systemic lupus erythematosus, lithium intake, hyperparathyroidism and sarcoidosis. So in view of the above reports, we had sent for a Schirmer's test, which was positive with dry eye of 4 mm value in both eyes. ASIA-EULAR criteria for Sjogren's was positive with a total score of 4. So we were able to diagnose her as Sjogren's syndrome. So patient continued to have multiple episodes of vomiting. We suspected to be a Sjogren's associated gastroparesis, and we added an etopride, a prokinetic, after which her symptoms had improved. So another few things that were in our mind at this time was the generalized lymphadenopathy, the persistent hypokalemia, autoimmune hemolysis given by the DCT positivity, the hypocomplementemia and paracortical hyperplasia. So in this, we wanted to consider a possible systemic lupus erythematosus also. I would like to mention here that paracortical hyperplasia, there has been one study which is shown that in few cases of lupus, that paracortical hyperplasia has also been found. So we consider the EULAR criteria at this point, and the patient was satisfying 13 points out of the whole. So more than 10 points is diagnostic, so we had considered a possibility of SLE diagnosis at this time. So we had started the patient on Septran DS 202 for toxoplasmosis, and also we had started her on prednisolone 30 mg OD and mycophenolate mofetil 500 mg BD in view of the Sjogren's SLE overlap. However, the very next day, the patient developed organic psychosis with delusion of persecution. We had considered a steroid-induced psychosis, and we had withheld the prednisolone and started her on risperidone after a psychiatric consultation. Patient improved with this, and they had requested for a discharge. So at this point of time, our diagnosis is an overlap between Sjogren's syndrome and systemic lupus erythematosus with associated gastroparesis, distal renal tubular acidosis, and toxoplasmosis. So after 1 week, again the patient had come back to our casualty, and at this time she had complaints of fever with a rash. She had the fever with rash for 5 days duration. On examination, there was an erythematous blanching rash, predominantly over the back and cheeks. Dry mouth, dry lips were present. Oral ulcers were also present. Initial labs were again showing an anemia with a procal of 1.21. Sodium of 126, hyponatremia was present, and an acute kidney injury of creatinine 1.24. Hypocomplementemia was still present. Our differential diagnosis for the fever with rash included a drug rash or an SLE, but the rash subsided within 24 hours of stopping Septran DS, so we concluded it to be a drug-induced rash. However, the patient's oral ulcers did not subside. So we had not restarted steroids at this point of time in view of the elevated procalcitonin and the previous history of psychosis. So blood cultures, urine cultures and COVID RT-PCR was again done, and these were all negative. So we had started the patient on IV azithromycin, but patient was not tolerating this and had multiple episodes of diarrhea. So then we had started the patient on pyrimethamine 100 mg stat followed by 50 mg with a leucovorin rescue of 15 mg once daily dose. Here again, the patient had further episodes of psychosis and auditory hallucinations. At this point of time, the patient was not on steroids. So we had done an MRI brain which was reported as normal. So because of this, we had considered a possibility of lupus-induced psychosis. So we had started the patient on a small dose steroids, 10 mg, with a risperidone trihexyphenidyl cover. With this treatment, the patient responded symptomatically and she did not have further psychosis episodes. Revising our EULAR criteria for SLE, we now had 2 more points to include. Patient had oral ulcers and psychosis, so a total score of 16 was present. So this time the patient was discharged again with an overlap of Sjogren's and systemic lupus erythematosus with complications of psychosis, gastroparesis and a possible distal renal tubular acidosis with toxoplasmosis in the background of an hypothyroidism. So then the patient had followed up in our OPD after a span of 1 month, and on follow-up the patient was doing symptomatically better. We were able to taper the steroid dose to a dose of 2.5. Mycophenolate mofetil we had hiked up to 500 1.5 BD. With this, the patient was doing symptomatically better. So now coming to why I titled the presentation as catastrophe. It might be quite obvious why the first 3 letters indicate. So the patient initially came with a single lymph node, and on evaluation we had found the patient to be toxoplasma positive. So usually toxoplasma is seen in immunocompromised host, but in this patient at the initial point of time the patient was immunocompetent. On further evaluation and further assessment, we had found that the patient had an underlying web of autoimmune diseases. So a few clinical pearls about toxoplasmosis. The causative organism, Toxoplasma gondii, and the host is a feline. Incubation period of 5 to 23 days after exposure. Diagnosis is by serology testing of IgM and IgG. IgM is usually positive within 1 week of exposure, IgG within 2 weeks and persists for months. But here we should note that when IgM is positive but IgG is negative, even after 2 to 3 weeks of exposure, IgM can be considered as a false positivity, which is why IgM and IgG needs to be positive in my patient. The treatment, the initial first line of treatment is the pyrimethamine, a 100 mg loading dose followed by 50 mg OD with a leucovorin cover, given for a span of 2 to 4 weeks. The second line of treatment is a trimethoprim sulfamethoxazole, and the third line being azithromycin. However, in my patient, we had initially started on a Ciptran DS. This is because pyrimethamine was initially not available to us, and we had to actually resource pyrimethamine from the hotline. And since the patient was initially not tolerating trimethoprim sulfamethoxazole, we decided to outsource pyrimethamine from the hotline. So I want to thank the treating doctors and my HOD, Dr. M.G.K. Pillai sir, and the treating doctors for this case and for the guidance. Thank you.
Thank you very much, Dr. Eunice. Any questions from the audience? So if no questions, I would like to wind up this session, and over to you, sir. Thank you very much once again for the opportunity.